Assalamu alaikum and good evening to you all. Welcome to the Health Talk on Acute Medicine, organized by SB Bangladesh Chapter and supported by Bangladesh Society of Medicine. Today, we have come to the 9th episode of our Health Talk on Acute Medicine series. On this episode, we are going to talk about a very important topic in acute medicine. Today's topic is AKI or acute kidney injury. To talk about this important topic, yet very life-threatening topic, we have someone who had perfectly dealt with such type of condition many times during his lifetime, whose up-to-date diagnosis and treatment has saved many lives and still counting. He is none other than Professor Brigadier General Mamun Mostafi sir. He is the Chief Nephrologist in the Ganashastha Kendra and member of Executive Committee, Bangladesh Society of Medicine. To chair the session, we have our very own Governor-elect of SCP Bangladesh chapter himself. A true leader, a prodigy in the field of medicine, Professor Khan Abul Kalam Azad sir. He is also the former president of Bangladesh Society of Medicine. As a panelist, we have two most renowned professors of our country. Firstly, we have someone who is famous for his extraordinary diagnostic skill. My mentor, Professor MD Zahir Uddin sir. He is the head and professor of medicine, Popular Medical College and member executive committee, Bangladesh Society of Medicine. We also have every student's favorite professor, a perfect example of an ideal teacher and an outstanding clinician, Professor MD Mahfuzer Rahman sir. He is the head of medicine and vice principal of Rangpur Medical College. To moderate today's program, we have one of the brightest new stars in the field of medicine. The amazingly talented, the champion of ACP Doctor's Dilemma Competition 2020, Dr. Mahbub Mayukh Rashid Bhaiya. He is currently the Register of Medicine, Popular Medical College. During the live session, you can ask topic-related questions on the comment section. We shall try to answer them in the question and answer session, which will start right after the presentation. So, without doing any further delay, let me hand over the session to Dr. Rashid Bhaiya. Dr. Rashid Bhaiya.
Thank you, Dr. Prince Kawser, for a nice and warm welcome. And I am Dr. Mahbub Rashid. I am Register of Medicine in the Popular Medical College. It is a great honor for me. I have participated for SAP Bangladesh chapter in the Doctor's Dilemma program, which held in USA as a country captain. And today I am moderating this session. So it's a great honor for me. As Dr. Prince already introduced the great speakers and the panelists and the chairperson of this session, I am shortly again telling the name of them, and in case any of us join late. Today the topic, the acute kidney injury, which is a very important topic, and we face difficulties in management and difficulties. We have many questions regarding this interesting and important topic. I think after the session, it all will be clear. And to present this, one of the greatest academician of our country, Brigadier General Professor Dr. Mamun Mostafi sir, who is also the Chief Nephrologist of the Ganashastha Kendra and the member Executive Committee of the Bangladesh Society of Medicine, will present this class. And I am handing the floor to now Professor Brigadier General Mamun Mostafi sir to start the proceeding.
Bismillahir Rahmanir Rahim. আমাকে শোনা যাচ্ছে?
হ্যাঁ, শোনা যাচ্ছে স্যার।
At the outset, I am very much thankful to the Almighty Subhanahu wa Ta'ala to allow me to be here, and many thanks to all the governing body of the SAP Bangladesh chapter and Society of Medicine to select me as a speaker of these very important sessions. I will present the presentations in these sequences subsequently. So, just short of the acute kidney injury, in the 2nd century, Mr. Galen could surmise that urine from the kidneys, that is the beginning of the kidney function. 330 to 1453, the terms oligura came out as a symptoms of the then acute renal failure, now AKI. And subsequently, they have already recognized that the polyuric phase could be also there as a recovery phase. In 1827, English physician Richard Brig described microscopic hematuria and oliguria and edema could be part of the acute or chronic renal problem. In the World War I, the observation was very significant. The thirst and oliguria in combat victims after the war had a definite relationship between blunt trauma and AKI. Post-traumatic oliguria seen in the combatants' crash syndromes that ultimately evolved AKI. In 1960s, it was found retrospectively that after open heart surgery, there is a incidence of 20% about AKI in this group of patients. The term AKI has been changed, all of you know, because of two reasons. Acute renal failure indicates a very bad thing, something failed. But creatinine of 1.4 and 9.4 is not similar. So whenever somebody says his relations that his kidney is failed, so there becomes a panic in the whole society of the patients and his relations. That was one thing. And this acute renal failure term does not explain the arena of the injuries. So that's why the acute kidney injury term has been introduced, and there are some stages in this AKI. There are a lot of definitions. In fact, we the clinicians express our own way how we feel about the AKI. But most simple way that I can feel that clinically AKI is characterized by a rapid reduction of kidney function, and that results in failure to maintain fluid, electrolyte, and acid-base homeostasis in the body. But there is no hard and fast rule how you will explain AKI. But these are the consensus. These are the consensus that can be included in expression of the AKI. Whenever there is just 0.3 milligram rise of creatinine over the previous value. So it was 1.4, now it is 1.7. That is very significant. Or 0.9 is now 1.2. That is very significant. So just mere 0.3 milligram rise is good enough to doubt that the patient is having AKI. And definitely, if the creatinine rise is more than 50%, say if someone is having 1 and now it's 1.5, so that is definitely significant. But many a time, in many of the areas of our country and many of the part of the world, the serum creatinine is not available, and if it is available, it takes about 24 hours to get the result. So urine output can be a good criteria to suspect the patients of AKI. So that's why the AKI has been divided to stage the different levels of kidney involvements. I'll not go in details of this AKI classification or rifle classification because it is very clumsy. I will go to straight at the easier one. So here you can see that the creatinine value is there, urinary output is there. So if the creatinine, as I said earlier, is more than 3 milligram or 50% rise, that is 150 to 200 percent, or the urine output is less than 5 in over 6 hours, then it is stage 1. If the creatinine rises more than 200 to 300, it's stage 2. Urine output remains less for more than 12 hours, that is also stage 2. So here both the criteria are included. And stage 3 or dialysis dependent situation comes up if it is more than 300% or more than 4 milligram, and it is more than 24 hours, or anuria, complete shutdown for 12 hours. So more than 150 to 200 times, 200 to 300 times, more than 300 times. It is And oliguria for more than 6 hours, oliguria for 12 hours, oliguria for 24 hours, or anuria for 12 hours. That is the simplest way of defining or explaining AKI. Almost 7% of the hospitalized patients are found to be in different studies that they can have AKI. But critically ill patients, the number are very, very high. It's 36 to 67% in most of the studies. And those patients, about 10% of the ICU patients are having AKI. 20 to 70% of all the AKI dies, and about 80% of the patients who require renal replacement therapy dies. So that is a very grievous condition. Here I want to show the relationship with the creatinine and the renal function. So whenever the creatinine is 1, GFR is 100 plus. Whenever the GFR is creatinine is 9, the GFR is below 20. So more the creatinine, less the GFR. That is definitely all of us we know. But here is a very important slide. So this is a 0 day, this is 7 day, 14 day. The patient has developed AKI, there is some renal insult. So from the very first day, his urine output fallen drastically. Then it will continue till it recovers, then gradually it will come up. But see here, the creatinine started rise on the second day, then it takes time to come up. So here the renal function has been destroyed, but creatinine has not come up. It's just 2, or it's just 1.5. So creatinine takes at least 72 hours to come up. But kidney function is better reflected in many types by the urine output. So this is one way of defining oliguric of AKI. This is oliguric or anuuric or non-oliguric. Oliguric is more seen in pre-renal form. Non-oliguric is in the renal form, nephrotoxic form, and sometimes, posternal form. But most important, this indicates a prognosis of the conditions. Those who are having oliguria, they have 25% mortality, 80% mortality, and non-oliguric has 25% mortality. So having some urine output is better, definitely better for the patients. Here, this message I want to put forward to all of the juniors. One person will say oliguria is less than 500 ml, or somebody says 400 ml. So 500 ml means 2 glasses of water or 2 glasses of liquids. So in a 12 hours, he should have passed at least 1 glass of urine. That is 250 ml. So whenever we come across a patients who do not have passed urine in over 12 hours or urine output less than a glass in 12 hours, definitely we should suspect a case of AKI in this particular patients. So 1 glass in a day. So these are the risk factors, all of us we know, but just to recapitulate, in any form of renal problem, if the patients get some sorts of injury, there is more chance of getting AKI. All types of sepsis, a diabetic patient, a cardiac patient, a hepatic patient, a patient who has neurological features, those who are already on nephrotoxic drugs like NSAID or some immunosuppressants. So those who have used contrast recently, they have some urological obstruction or something like that. And obviously, if they are elderly, so that is also a risk factor for the AKI, developing AKI. So this is traditional. To function a kidney properly, it requires normal blood flow. So if there is jeopardy or impairment of the renal blood flow, it becomes pre-renal. We require functional glomeruli, tubules, and interstitium. If something happens in either of these, it becomes a renal or intrinsic. And if after formation of the renal, it cannot come out through the normal outflow tract, it is postrenal. So here I am summarizes the pre-renal causes. So in a hypotension, which could be cardiogenic shock, which could be distributive shock because of the sepsis and anaphylaxis. It could be hypovolemia because of hemorrhage or volume depletion like vomiting, diarrhea, or diuretics overuse or burns. If there is cardiac output is less because of the edema-associated like cardiac failure or cirrhosis or nephrotic syndrome. If there is vasodilation because of the vasodilating drugs, all this causes to reduction of the renal blood flow. So there is reduced GFR and ultimately pre-renal AKI. So these are the causes of intrinsic or renal causes of AKI. These are 4 heads. So this could be glomerular, this could be tubular, interstitial, in between the tubules, and vascular. We all know this is glomerulonephritis, which could be post-streptococcal, which could be lupus, which could be vasculitis, which could be HSP or TTP or HUS. Acute tubular necrosis develops because of the toxins or ischemia. This is pre-renal likely. And interstitial because of the drugs, because of the infiltrations by something, which could be lymphoma, which could be sarcoidosis or tuberculosis, or acute pyelonephritis, which is very common nowadays in the hospital setting. There could be vascular catastrophe, there could be renal vein thrombosis, there could be renal artery occlusions by cholesterols. So you see the percentage here is 70 to 80% in the acute tubular necrosis. Second comes the glomerulonephritis or acute interstitial, and vascular events are quite less. Postrenal cause all of us know. This could be inside the lumen, in the wall, or in the pelvis. So I want to highlight some features of the different types of AKI. So if it is pre-renal, pre-renal means the kidney is having less amount of blood. So whatever amount of blood it gets, it will try to reabsorb. So the urinary osmolality will be high. So this is very important. Whatever amount of sodium is filtered, kidney will try to reabsorb all sodium. So sodium will be less. As such, the fractional excretion of sodium will be less. The glomerulus, interstitium, and tubules are all intact. So whatever urine will form, it will be normal, bland. And in a state of dehydration, the ratio of burn and creatinine will be high. And obviously, in ultrasonogram, kidney will be normal. But in case of ischemic or a development of acute tubular necrosis, the tubules cannot reabsorb. So the urine will come out dilutely. So most of the sodium, as the tubules are sick, the sodium will not be absorbed, so sodium will pass. So fractional excretion of sodium will also more. And here the tubular cells will form cast, then they will become disintegrated and they will form dark pigment. I'll show a picture of the dark pigment later. And this glomerulonephritis or interstitial nephritis, here also the glomeruli are sick, so the part of the the reabsorption mechanism will be also affected. So the sodium will be more in the urine. Excretion of sodium will be more. Sorry, it is interstitial nephritis, I'm sorry. So in this situation, the cause of reflection of the anaphylaxis or allergy, the eosinophil count will be high, and the intestine will not absorb the sodium, so the sodium excretion will be high. And as a result of the infection or inflammation, more WBC and RBC will be formed, and in the tubule there will be formation of the cast also. In glomerulonephritis, the most characteristic features always teach our students. There will be hematuria, there will be RBC cast, and why hematuria and dysmorphic will be dysmorphic. As the glomeruli has to pass through the basement membrane, the RBC has to pass through the basement membrane, so they will be squeezed, so their cell will be teared, and so they become distorted. That's why they will be dysmorphic. And this RBC will remain in the tubules because glomeruli are filtering less amount of blood, so the flow in through the tubules will be less. So whatever RBC is filtered, they will become stuck up with one another and will form RBC cast. So at the same time, as there is leakage in the glomerulus, the most abundant protein in the blood, that is albumin, will also come out in the urine. In postrenal, everything will be near normal. Urine will not give any idea about what happened, but the ultrasonogram will become diagnostic in this situation. So this is the summary of what I have said so far. This is the formula how we calculate fractional excretion of sodium. So if it is less than 1, it is pre-renal. If it is more than 2, it is acute tubular necrosis. This is also a summary of the renal findings in different type of conditions of the. So in glomerular disease, as I said, there will be hematuria, red blood cell cast, heavy proteinuria, and lipiduria. And in case of interstitial nephritis, tubular disease, there will be pyuria with white cell and granular casts. So if we suspect a case of pre-renal AKI, what we should look for in the history, what the intern will go to ask the patients. So definitely whether any history of hemorrhage, hypotension, hypovolemia, GI loss, or pancreatitis or thyroid space loss, or any evidence of cardiac failure. Or is there any sepsis? If there is any sepsis, we have to look for what is the source, whether it is in the intestine, whether in the lungs, or somewhere else, or inside the kidney. So this history was very important in case of pre-renal AKI. And in these situations, in pre-renal AKI, the patient will be of hypovolemic, dehydrated, and definitely there will be rapid pulse and blood pressure will be low. This low BP is very important because post-renal patients will not have low BP. Renal patients will maybe have a high BP. So low BP in a patient of AKI, definitely we should look for anything pre-renal. So as the patient is hypovolemic, maybe in shock, so there will be features of shock and cool extremities. The capillary refill time will be more than 2 seconds. Patients will get vertigo whenever he gets up. But it can be have different. If the patient is febrile, toxic, bounding pulse, low BP, definitely there is having of sepsis. So in these situations, there will be other features of dehydration and JVP may not be able to detect it. In renal origin of AKI, I must say that if the pre-renal conditions persist for a long time, so this pre-renal situation will produce necrosis of the tubules, and that hypoxia, if persists, it will produce glomerular injury also. So pre-renal will turn into renal if it is persist for a long time. So in the history of renal AKI, there can be history of preceding hypotension or hypovolemia or blood loss. Then the patient will have hematuria because glomeruli has become inflamed and there is leakage of blood through it. So as the glomeruli are sealed off, it cannot filter. So this fluid will not go into urine, and they will come out, they will fill up the blood vessels, and from there, with increased hydrostatic pressure, it will produce in the interstitial space and edema and puffy face. So not only puffy face, there become anasarca, and that can go inside the lungs and produce pulmonary edema even. So that will produce. Here, one thing I forgot to add here, there will be high blood pressure, because this amount of fluid, we know that about 5 liters of blood is in our circulations. So whenever there is low filter, there is no urine coming out, so this intravascular volume will become high. Patient will say that there is no urine output, so they will take more water. So the intravascular pressure volume will become more and more, and that will lead to more intravascular pressure. So there will be high blood pressure. So patient will get two types of symptoms. One is fluid overload and is symptoms of blood pressure. So blood pressure related symptoms could be headache, nausea, vomiting. There could be left ventricular failure, or there could be fluid overload and shortness of breath. So if there can be hypertensive encephalopathy, or because of the uremia, the patient can have unconsciousness or even seizure. One thing, in case of renal origin, as I said, there could be vasculitis, lupus, so patient may have features of fever, rash, and arthritis also. So in this situation of renal AKI, what we will look for? So there will be edema and anasarca, there will be hypertension, JVP will be raised, there could be features of the ventricular failure, the lungs will be flooded with crepitations, there could be signs of any other sepsis anywhere, there could be ascites, and because of the systemic disease, we could have liver and a spleen. And obviously, there will be low urine output. But in case of doubt, we should examine the bladder, and if there is doubt, we should have a catheterized to confirm that there is no urine. But that should be very rare. So we will also continue to look for any features of connective disease like rashes, skin changes, arthritis, any history of bleeding problems, or uveitis, oral ulcer, any new neurological signs, or it can be features of endocarditis. Biopsy is indicated if we cannot diagnose the patients by our history, by our examinations. So in that case, especially if the AKI is of renal origin and there is no clue why it has happened, then we should do a biopsy. Why will do biopsy? Biopsy will give a definite specific histopathological diagnosis, and on the histopathological diagnosis, we will decide what the management protocol will be there. And biopsy also will tell that how much the patient will respond with this treatment and what would be the prognosis. So in case of renal AKI, biopsy is a very important and a specific diagnostic tool. I am showing some slides of the acute tubular necrosis to make it a better understanding. Here is the renal cortex and medulla. So you see that the oxygen saturation in the cortex is 50, in outer medulla is 20, but inner medulla is 10. So whenever there is vasoconstrictions, whenever there is ischemia, so this will go fast. So this tubular injury will occur here. So there is no cortical tissue. So the tubular cells are compact here. They will have necrosis and destroyed fast. Then gradually it becomes more peripheral. After an ischemia, this is a normal tubular epithelial cell. After an ischemia, the polarization is lost. Then the cell gets ischemic and necrosed. So they get apoptosis and cell death. Then dead cells slough out. I'll show how these slap out cells, what they do. So the area becomes necrosed. But whatever it is, a few cells remain or some cells migrate to the tubules if the patients remain viable for about 4 weeks. So new cells come in the tubules or new generations takes place. So they will proliferate, and in about 6 weeks of time, a normal epithelium will come out in the tubules, and then the kidney function will recover. And during these 6 weeks, we may have to support the patients with dialysis and other renal supports. These slap out cells will come out from here and will block the tubules. So whatever amount of urine could be coming out, it has been blocked by the tubules. So there will be gradual reduction of the urine output and oliguria, maybe anuria also. As I said, creatinine will take 42 hours, 48 hours, or even 72 hours. And urine output, many of patients, if you are unconscious, drowsy, they will not be able to say. So we require some biomarkers to detect whether the kidney is in problem or not. Actually, these things are rarely done, but we can do it. This beta-2 microglobin can be increased in acute tubular injury. And most important, this is worldwide accepted, but very small amount is available in our country. Neutrophil gelatinase associated lipocalin, NGL. Whenever I was in CMH, one of our student now, a Professor Colonel Ajijun had her thesis on this. So this is a very good, this is a dipstick test, can be done anywhere in the emergency department. This can give an idea that the patient is going to have AKI. Posternal is a surgical issue, but the thing history should be, we should know how to take the history. So there is definitely lower urinary tract symptoms like frequency, urgency, dysuria, nocturia, poor stream, hesitancy, terminal bleeding, strangury. These are the prostatitis. The patient, the frank hematuria will be there. Could be microscopic hematuria, and more important is low end pain. Low end pain can occur in the renal AKI also, because the capsules are stressed, but there will be dull aching pain. But postrenal AKI pain will be of colicky pain. So here, examination will reveal a palpable kidney or palpable bladder. There will be visible hematuria, and if we do a prostate examination, there could be prostatic mass or prostatomegaly. This has been discussed so far. So after these slides, possibly this is a time to say something about the AKI in COVID also. In COVID, most of the patients developed AKI in 7 to 14 days of admission. The 2 and 3 stage of AKI, as I said in my initial classification slides, 20 to 30% plus patients and 25 to 30% patients are treated with renal replacement therapy of these patients. Total amount of AKI in COVID could be about 9%. But 15% of the total AKI may require renal replacement therapy. (65% patients of the ventilators developed stage 2 or stage 3 AKI, compared to 7% those who are not ventilator. Those who are on ventilator, almost all the patients are those who require RRT are on ventilator. Here, I want to show that in this study of 701 patients in China, they found about 50% of the patients has proteinuria, and 13% had increased creatinine and elevated BAN and altered GFR. This was published in Journal of American Society of Nephrology. Here you see that 75% patients have some form of hematuria, proteinuria, or AKI. So AKI is not uncommon. It's quite common in COVID patients. Here you see the days of development AKI. The first step, a huge number of patients come up with the AKI. This AKI in COVID is mostly pre-renal because of the patients who are COVID having fever, anorexia, nausea, vomiting. They can't take food sufficiently. Moreover, many of the patients are taking NSAID for their body ache and headache. So this initial AKI is mostly pre-renal. Then the patients comes in the hospital, but after the second week, it becomes rise because of the involvement of the kidney. I will discuss a bit less soon. This is the number of admitted. This is the number of discharged, and this is number of expired. So no AKI, most of the patient discharged. Stage 1 AKI, maximum patient discharged. Some are dead, few. These are the admission. Almost all are discharged. But in case of stage 3, so these are the patients. These are the patient expired. So there is the more severe, more mortality. So this is how COVID involves kidney. This is I have so far already discussed. This is the initial AKI in COVID, which has been developed, because of the pre-renal element, as the multi-organ involvement of COVID, dehydration, different types of drugs, including remdesivir. This is also nephrotoxic, and development of shock. But there is, interestingly, the virus has been found in the renal glomeruli and in the interstitium. Viral particles that have been found in the kidney, they have been cultured and they have proliferated in the culture media for a huge number of virus. So it has been proved that the virus multiplies inside the kidney. So because of the fever, because of the rigor, because of the toxin, there are elements of rhabdomyolysis also. And because this COVID produces antibody, and this antigen-antibody reaction can also produce a type of glomerulonephritis here. And as the patients develop coagulopathy, there could be features of HUS or TTP or DIC. And obviously, there is no doubt that AKI can have on a pre-existing patients who have a CKD or something like that. So these are the way how COVID involves kidney. So after discussing so many things or so less things, if one of our trainee or if intern comes with a patient's report that his creatinine is high, what he or she should do? Because if we can diagnose at the outset this patient is of AKI or CKD, a lot of investigation could have been avoided. And a lot of, in fact, patient's agony, doctor's agony can also be relieved. So you all know that if there is pre-existing history of any comorbid conditions, there is chance of CKD is more. But one thing, as I said in the COVID chapter, a pre-existing CKD patients can have AKI on CKD also. So the presence of diabetes mellitus or presence of SLE does not mean that the patient will not have AKI for the de novo. So these are the things which you should look for to isolate these patients of CKD. So nocturia, very important. Many of you do not ask about the nocturnal history. A leukonychia, presence of leukemia is a good enough sign for showing that the patient is having CKD. There is pigmentation, they look dry matte color. Anemia, though, it can develop in AKI also because of blood loss. So a presence of nocturia, a pre-existing conditions, and leukonychia. This is good. These are very important, helpful points to suspect a patient of CKD. So as I discussed so far, urine will look all these things whether they are present or not. In a patient of CKD, if the kidney size is normal, presence of these things means that we can still do something for the patients. This is we usually forgot. Whenever a CKD patient comes with creatinine 4, and we do say there's nothing to do, just take blood pressure medicine and diabetic medicines if so. But many of the patients we're having acute active nephritis. If we could treat this active nephritis, we can slow or halt the progression of CKD in these situations. So presence of active urine sediment in case of CKD, we should alert that we could do something. So this is dysmorphic RBC. See, this is a near normal RBC, but see, these are the RBC, how distorted they are. So this RBC, while passing through the basement membrane, they become distorted. So these are the RBC in the urine. So this RBC inside the tubule, they become stuck up with one another in the tubules and has taken the shape of the tubules, that is the RBC cast. But in the acute tubular necrosis, the tubular cells, they are already sloughed out. They are already dead. This RBC is not dead yet because their life has filtered through the glomerulus. So these dead epithelial cells, they disintegrate and form granular cast, but this color is definitely brown, mud color. This is very typical of acute tubular necrosis. This is eosinophil in the urine. A presence of single eosinophil in the urine is very much characteristics of acute interstitial nephritis. So if we can find out one eosinophil by special stain in the urine, we can definitely look for interstitial nephritis, and this is a rewarding condition because acute interstitial nephritis of allergic origin can be very nicely dealt with, treated with, and patient can be recovered 100%. So we should see this, so whether there is an infection, whether there is eosinophilia, or there is thrombocytopenia due to coagulation disorder. In AKI, we should follow these patients daily with this biochemistry every day. We should check for the CPK and myoglobin in the urine because a rhabdomyolysis also can happen in any infection condition, as I said in fact, most of the patients in my two hospitals, whenever they developed AKI, you will be surprised that most of them also having raised CPK values because of many reasons. So in a patients of sepsis or progressing AKI, we'll definitely look for disseminated intravascular coagulation features. And definitely, if the patients are not diagnosed with those previous investigations, we should look for the lupus and vasculitis. So renal ultrasonography will be normal in AKI, but maybe the kidney may be enlarged to bit. Normal kidney size in our country is 9 centimeter plus minus, but in AKI you may get a kidney of 11 centimeter plus. We should do chest X-ray to see whether this patient is having pulmonary edema, whether the patient is having an infection in the lungs, whether the patient is having any features of connective disease in the lungs, or the patients may have an enlarged heart leading to cardiac failure. So, who are the juniors are in these presentations? You can have a practice. A 10-year-old girl presented with serum creatinine of 2. She also said that she is having oliguria, hematuria, puffy face, and her blood pressure is 150/100. So what is this? So hematuria, hypertension, and azotemia. So definitely is a case of glomerulonephritis. Then if it is a case of glomerulonephritis, then we'll look the history, whether it is a post-infectious or post-streptococcus, or it is a lupus or a vasculitis. So your investigations will guide you what type of nephritis. So it is a renal conditions, and you'll definitely investigate accordingly. In another situations, a 20-year-old farmer has reported with 2.2 creatinine. He reported with severe acute watery diarrhea and vomiting for 2 days. And he has not passed urine since yesterday. So though the blood pressure is not here, so this very typical history says that because of the diarrhea and vomiting, patient has developed hypotension, leading to dehydration, leading to pre-renal AKI. So it is pre-renal or renal? It's pre-renal. Definitely, why the patient has vomiting and diarrhea, we have to see. Physical examination will say that patient is in shock or not, and will investigate. Here, the investigation will be mostly bland. In a 43-year-old man, creatinine is about 5. He was having low blood pressure, low back pain for last 6 months, along with irregular fever. His family physician advised naproxen, which he is taking for the last 2 months. So now we have to see whether this is an AKI or CKD. If it is AKI, whether it is pre-renal or renal. So likely the patient is having an NSAID-induced renal impairment, or as there is fever and low back pain, the patient might have other conditions of the spine like myeloma or an infection. So the history examination will definitely guide us to the diagnosis. So far, after discussion, because AKI presentations in a single session is very difficult, but I wanted to amalgamate to sum up some of the things that we face clinically. So what we should do, what a duty doctor, where a junior doctor will do at the outset whenever he gets a case of AKI, after confirmation and history and medical examinations, he will confirm AKI. Yes, it is AKI, not CKD. Because if it is AKI, I have to do something. And if it is CKD, okay, I can wait, I can see what I can do, what best for him. But if it is AKI, the doctor cannot leave the patients. He have to manage the patients. So then it is there any emergency related to AKI, whether he's having shortness of breath, whether he having acidotic breathing, whether he has got features of hyperkalemia. How will have hyperkalemia clinically diagnosed? Can we diagnose hyperkalemia clinically? Yes. In a patient of stress, in a patient of shock, in a patient of whose creatinine is high and is in shortness of breath, her pulse should be more than 100. But in a situation of shock or in a situation of acute emergency, if the his pulse is less than 60, is most likely because of hyperkalemia. So less pulse in a case of acute emergency, we should always suspect there is something happened to heart, might be hyperkalemia. So after this, if there is no emergency, have a full checkup of the whole system, including the bladder. If required, give a catheter to see that whether he is having really urine output or not. Check the blood medicine, stop all the possible drugs which can cause kidney damage. Bedside dipstick test can give us whether there is any protein, whether there is blood or sugar. If you find there is blood in the urine, we should definitely confirm with routine examination. Then we should send the biochemistry, we should do an ultrasonogram, and don't forget to the chest X-ray, as I said, why you should do that. So after this, I cannot discuss the management in details because management of AKI is one of the largest chapter in nephrology. So what we should do first? The first thing is we should assess the volume status. That is the most important thing. I can do good to the patient, I can do harm to the patients. Volume status is if it is low, if it is dehydrated, if it is hypotension, if there is features of sunken eyes and others. If I do not give fluid, rather if I restrict the fluid, I will cause death sentence to the patients. Because in a case of pre-renal failure, if I infuse the patient with saline, the patient will come up in next 3 hours. But if inadvertently creatinine is high, so the patient has to give volume restrictions, I will ensure that the patient's kidney will be damaged 100%. So that is the most important thing for an internist. In the ward or in the OPD, what is the volume status of the patient? So to decide whether to infuse or to restrict fluid. then manage the emergency, whether the patient is short of breath, whether the patient has been convulsion, whether the patient has been fever, whatever it is. So after the fluid, come to the emergency. And so after the an emergency patient, a pulmonary patient can also have fever. So identify whether they have features of infection anywhere. And we have to treat with a definite possible antibiotic which is directed to the organ involved. In case of bleeding, we should be very keep in mind that AKI, renal impairment itself can cause bleeding deficiency by platelet abnormality. So we should transfuse, we should use PPI in these situations. Nutrition is a big chapter. Most of us, including nephrologists, have got many of us do not have concrete idea what the nutrition means for the patients. In a patient of AKI, patient should have a high calorie diet, because this is a state of catabolism. All the protein will be broken down by the stress hormones, and the patients will become cachectic and wasted in a very short period of time. So during this time, patient will have high calorie, mostly carbohydrate, and including protein of about 1 gram per kg per day. In fact, nutrition is an important chapter because all the patients will not have hyperkalemia. Many of the patients may have hypokalemia even because of the interstitial nephritis. Many of the patients have hyponatremia. So restriction of salt, restriction of fruits is not mandatory for all the patients. So whatever the drugs we will give, we'll adjust the medications according to the ZFR. We'll avoid the drugs which is not required. We'll monitor the patient's intake and output with daily weight measurement and daily serial assessment of the serum creatinine and electrolytes. We'll consider renal replacement therapy. I will touch up a few slides soon. So whenever the patients require dialysis, the dialysis should be given earlier, because this creatinine, what I say to my patients, kidney has got two most important functions, just to excretion of the waste materials and excretion of extra water. Whenever kidney shuts down, kidney cannot pass water, so it becomes accumulated in the body and in the lungs, so there is shortness of breath. And kidney cannot excrete the waste materials, that creatinine and others, so this creatinine will remain accumulated in the body and will harm to the brain, heart, kidney, everywhere. So if it is very high creatinine level, it will definitely have a hazardous effect on the brain and others, and the patient become uremic. So we have to remove this waste materials, creatinine and extra water by dialysis. The simple way that I can explain to my patients. So when we'll give dialysis? These are the indications that all of you know. Just I have to give a slide, that's why I have given this slide here. So if this refractory volume overload, whenever there is volume overload, there is always an indication of high dose of diuretics. If the diuretics can help by excreting the fluid, the patient can take some food, some water. But if there is no urine, we can't give any fluid to the patients. So diuretics has a definitely important role in the management of fluid overloaded AKI. So if the patient is acidotic of pH less than 12, pH less than 7.2 or bicarbonate less than 12, hyperkalemia more than 6.5, or there is features of pericarditis, seizure or neuropathy, or there is bleeding because of the uremia, or the patient has taken something which can be dialysable, we should not wait for the dialysis. We should not wait that the patient kidney will come up and dialysis not be required, because this dialysis will be temporary. Most of the patients will come up after if we get proper dialysis. So dialysis should not be discouraged in case of AKI. So ladies and gentlemen, and thanks to all the SCB chapter of Bangladesh and whoever is attending these sessions, I have almost come to finish my presentations. AKI is very common in the hospital setup, and it carries a high mortality. I have already shown the patients who are at risk, especially elderly patients and those who have other comorbid conditions. Many of the AKI are preventable, especially the pre-renal one and the drug-induced one. Rapid recognition at the first visit is the most important, and he is the most important physician for an AKI. This is to be very highlighted in all our lectures by the internists. So, ladies and gentlemen, that's all from me. Thank you very much. If I can answer any questions, it's my privilege and it's my pride. Thank you very much.
Thank you so much, sir, for this amazing, short, yet very informative presentation. I can see the whole comment section with many questions, but I firstly apologize. We can answer only few of them as the time is short. So now it's time for question and answer session. I would request Dr. Rashid Bhaiya to start the question and answer session. Dr. Rashid Bhaiya.
Thank you, Prince. Sir, there are many questions. I'm picking some questions from the question box. So there is a question about that, sir, most of the hospitals don't have the facilities to measure the urinary sodium. How to biochemically differentiate pre-renal and post-renal AKI in such setting?
Pre-renal and renal with the internist has to diagnose by our clinical eyes only. Pre-renal has the history and examination is clearly defined which is pre-renal and which is renal. But pre-renal has got disproportionate rise of urea than the creatinine. Usually they go side by side, but in pre-renal urea will be more, will rise more than the creatinine.
So another question is about the, sir, will you please tell me the scope? Mizan Rahman, Doctor, asked this question. Scope and limitations of renal biomarkers in AKI. So I am combining another question with this. How to do NGAL? There is another question, sir.
NGAL is a dipstick test. Like the dipstick urine test, it comes in dipstick. We just have to put the dipstick inside the tube or inside the test tube, and we'll give the result whether it's present or not. It's very simple, but it's not available in the country because it's costly. This is second question. Second part. First part of the question was
scope and limitations of renal biomarkers in AKI.
Yes, we do not have. In fact, thank you. You are very concerned. I appreciate your concern, but in most of the hospitals, this is not available.
So another question is that regarding the choice of fluid, normal saline or heart sol is the best choice of fluid in which case of AKI?
It is always normal saline because heart sol. We should see the other electrolytes also, and that will guide whether it will use a heart sol or not. But normal saline has got no contraindication. We can always use normal saline as the first choice. Then we'll do the electrolytes and then subsequently choose whether these are cholera saline, because many of the patients get hypokalemia in that cholera saline. If the patients have got bicarbonate less, then we can choose others also. So first choice is always normal saline.
Thank you, sir. I'm taking the last question. Sir, is the dose adjustment of antibiotics necessary in a confirmed AKI patient?
Yes. Because many of the currently used antibiotics, which are used as a second line, are all nephrotoxic, like meropenem, like even some cephalosporins and these quinolones, especially the levofloxacin, ciprofloxacin are all nephrotoxics. Only moxifloxacin is said to be nephro-friendly. And the vancomycins, then tetracycline, no one is safe. So once there is AKI, we can calculate the GFR and we'll definitely advise the drugs according to the GFR values. And definitely, I appreciate your concern. Thank you very much.
Thank you, sir. There are also many other questions, but I am concluding the session, question answer session now. Handing over to Dr. Prince. Okay, I can proceed with the program now, as we have two panelists with us, and the great academician. Both of them are great academician, very well-known face of the internal medicine facilities. And I'm requesting Professor Mahfuzer Rahman sir, head of the medicine and vice principal of Rangpur Medical College, to say something about this presentation. Mahfuzer Rahman.
Thank you, Dr. Mahbub, moderator of this session, and Dr. Prince, host of this session. Today's chairperson, my respected teachers, as well as my beloved teacher, and the eminent professor, Professor Khan Abul Kalam Azad sir. And today's speaker, my another honorable teacher and beloved person, Professor Brigadier General Mamun Mostafi sir, my another senior person and senior teacher, Professor Muhammad Zahir sir, and the respected participants. In my speech, at first, I'd like to express my thanks and gratitude to ACP Bangladesh Chapter and Bangladesh Society of Medicine for keeping me in this gorgeous session. And the today's topic regarding acute kidney injury, really I have nothing to say, and I feel shakiness because today's speaker is a renowned physician, and really Professor Mamun Mostafi sir presented the topics in a nice and elaborately, and the presentation was so palatable. Throughout the session, I enjoyed the topic, and but I would like to draw some points from his presentation as a home message that I'd like to convey to the participants. Considering our context, the acute kidney injury, I think it's a important medical emergency, and the etiology, if we consider in our context, most of the AKI are due to especially pre-renal or hypovolemic cause, and the septicemia, trauma like physical injury, poisoning, falling road traffic accident, use of nephrotoxic drugs, and as a part of multi-organ failure, and in settings of CCU as a cardiorenal syndrome, and certain patient may present AKI on CKD. And most of the causes, pre-renal, it is about 60 to 70%, it is said in certain papers, and renal around 20 to 40, and post-renal 5 to 10%. And whenever we consider the renal cause, we define the etiology in 4 categories. It might be glomerular, it might be interstitial, might be vascular and tubular. And ATN, that is acute tubular injury, is most of the important pathophysiological cause of renal cause of AKI. And what patients are susceptible to develop AKI in hospital settings? We have seen the risk factors, certain like aged person, diabetic person, hypertensive, having dyslipidemia, or who are a smoker. And regarding investigation, SAR said that usually urine microscopy, then urea creatinine, electrolyte, ultrasonography, and certain advanced tests which are essential to predict the signs of development of AKI, which are not widely available, like in galactosamine, interleukin 18, and kidney injury molecule. It is said in certain papers, kidney injury molecule. These are also important biomarker that might be done to predict the signs of development of AKI, because sir said that creatinine may require time to be raised, and if you predict earlier that the patient might develop AKI, we may retard or hold the speed of progression and we may reduce the morbidity and mortality or hospital stay of such patient. And what's about management? The most important thing that the volume status should be assessed first, whether the patient is hypovolemic or hypervolemic, and fluid electrolyte balance, metabolic acids addressing, as well as hyperkalemia, that should be kept in mind. And septicemia is one of the important causes, so use of antibiotic and tuning of nephrotoxic drug or withdrawal of nephrotoxic drug, and hemodynamic stability. Use of dopamine, it is said that use of dopamine is controversial, and the role of albumin, some role of albumin, and the use of vasopressor, ionotropes, it will depends upon the patient's physical condition and hemodynamic stability. And use of furosemide, sometimes it is used irrationally. It is only indicated in AKI with hypervolemia, and we should keep mind regarding the nutritional status of the patient. Sometimes it is ignored, especially the calorie requirement should be supplemented by lipid and carbohydrate, and protein restriction. If there is dialysis available, protein, moderate amount of protein is already said by teacher. The protein about 1.2 gram per kg per 24 hours, it might be given. And finally, some patient may require a renal replacement therapy. The use of sodium bicarb should be rational, depending upon the bicarbonate level and the features of metabolic acidosis. And another thing, sometimes the contrast nephropathy that might develop in hospital setting, especially in patient with coronary care unit, that should also keep in mind. With these few words, I would like to conclude my speech, and I would like to again express my thanks and gratitude to the Bangladesh Chapter ACP and Bangladesh Society of Medicine and all of my teachers who are present here, because I feel honored to be present as a panelist of this session. And again, I would like to express my thanks to today's speaker, my beloved teacher, Professor Brigadier General Mamun Mostafi sir. Thank you all. Thanks for patience hearing.
Thank you, sir, for your concise speech on this beautiful presentation by the Mamun Mostafi sir. Now I am requesting Professor Mohammad Zahiruddin sir, Head of the Department of Medicine and Professor of Medicine of the Popular Medical College. Sir, এটা unmute করতে হবে, sir. Sir, unmute হয়নি স্যার এখনো স্যার।
এখন হয়েছে?
জি স্যার।
আচ্ছা। Thank you, Dr. Rashid. I am giving thanks to the ACP Bangladesh Chapter Organizing Committee of the ACP Bangladesh Chapter for selecting me as a panelist in this session. And I also give thanks to the Professor Brigadier Mamun Mostafi for his brilliant presentation regarding AKI. So, dear participants, particularly the students, the first important things to identify a case of AKI. When a patient came to us, our first thing is that whether this patient have really AKI or not. And a patient come to us with a decreased urine output. You first things you have to identify whether it is retention or it is a really decreased urine output. If it is AKI, that is a decreased urine output, that is how long it is and how much urine is output in the last 12 hours. If it is less than 300 ml or approximately one glass of urine, it is definitely AKI. Or in the last 12 hours, no urine, it is a renal failure or it is AKI. So you first identify it is AKI or not. And then you take the history, whether it is a pre-renal cause or renal or posternal cause. It is clinically, we can identify it easily. If the patient have any history of volume loss, like diarrhea, vomiting, blood loss, burn, etc., or a patient it is a hypovolemic pre-renal cause of renal AKI, or if it is something cardiac cause, that is the patient have history of chest pain or MI, that is cardiogenic shock, that is another cause of pre-renal cause of AKI. And renal cause is typical history of decreased output with a swelling of the face at the very beginning. Patient present with the swelling of the face and decreased urine output with high colored urine, and sometimes the hematuria. It is definitely a case of a common cause of renal cause of AKI. The very post-renal cause, that is the obstructive uropathy of acute renal failure, is very uncommon cause. It is a common cause of chronic kidney disease for obstructive uropathy. So obstructive cause is very uncommon. Even then, some patient may came to us with AKI with post-renal cause, that is the patient with bladder neck obstruction or any stone impacted in the lower urinary tract, that is in the urethra. So that is very uncommon cause. In that case, patient may give this severe lower abdominal pain or decreased retention, as well as the decreased output. Creatinine may be high. So in that case, it is a post-renal cause. So the first important thing is it is really AKI or it is and it is really common cause, the pre-renal hypovolemic or not. If it is hypovolemic, you can do some few tests. Only you do the urine REME and you do the creatinine and you blood urea and you do the electrolyte test. In this few tests, and rarely and sometimes you can do the ultrasonography of the KUV region. And with these few things, you can identify pre-renal, renal, and post-renal cause, and with the history. In that case, most of the case, you can identify the common cause of AKI. Now, you can, regarding the management, you know what is the functions of the kidney. It is the main, the volume correction, the fluid balance, electrolyte balance, acid-base balance. In AKI, these are our target of management. So if it is hypovolemia, you first correct the volume correction. That is the very important things. And if it is cardiogenic, that is pre-renal cause, it is very uncommon. In that case, definitely patient needs specialized care. You can give the inotropes and you send the patient to specialized center, but you can start the inotropes. But common is the hypovolemic shock. You correct it first. And many of the times after correction of the hypovolemia, patient may recover early. And the renal cause is very uncommon cause. But you can do the urine examination. If they get the RBC cast and albumin, it is most likely it is a renal cause. So you treat the case with diuretics. It is a volume overload case. So fluid is in one case you give the fluid, in one case you restrict the fluid. That is a common cause. And now you manage the electrolytes imbalance. The commonest electrolytes abnormality is hyperkalemia. If you see the potassium level is very high, then you correct it. And obstructive uropathy, you first relieve the obstruction. So this is the few things as an internist we should know. In the other cases, that is specialized case, mostly in the renal cause of AKI. In that case, in some cases you restrict the fluid, you correct the electrolyte balance, and in some cases patient may need the dialysis. And in every case you should do no harm by giving some unnecessary drugs or unnecessary or under fluid or over fluid. That is the very important things. Giving the antibiotic, giving the NSAID. Those who are nephrotoxic, you should avoid it. So with these few words, I conclude my session. And again, I would like to give the thanks to Professor Mamun Mostafi for his very brilliant presentation. And also, I'm giving thanks to the organizing committee of the ACB Bangladesh chapter to give me the opportunity to say something about this session. Thank you all. Thank you.
Thank you, sir, Zahir sir, for summarizing it and give us the take-home message in a very beautiful manner. Before going to the chairperson of this program, I would like to request Mamun Mostafi sir to say a few words about our program of the ACPs. Mamun Mostafi sir, sir mone hoy disconnect hoye geche naki?
Sir is not currently present.
Yeah, nice.
Okay. Okay, then I am going to our chairperson of this program, Professor Khan Abul Kalam Azad, who is governor-elect of the ACP and very most famous and the legendary professor of our country, and ex-principal of DMC, now currently principal of Popular Medical College, Professor Khan Abul Kalam Azad, sir. I am requesting you to conclude the today's session and give some valuable speech for us. Thank you.
Thank you very much. First of all, the man who begins, Dr. Prince, for his excellent beginning. Today also his effort to bring everybody here and to provide all the possible arrangements to make a very successful meeting here today. And also anchoring the session, Dr. Mahbub Mayukh Rashid, who is very good not only in clinical aspect, and he is the captain, national captain of ACP, till we find another captain from our country. And his performance in the ACP session was noteworthy, and as because I was also present in the session, it gave me immense pleasure and gave me the thought that in the future, when we'll be departing, there are some people who will be there in the boards. And today's meeting, in fact, a series of meetings, and today is no exception, is such a wonderful thinking of our great governor, Professor H.M. Nazmul Hasan. And truly speaking, I wanted that Professor H.M. Nazmul Hasan should be there as the governor for next 20 years. Because he is making my task in the coming 4 years difficult and more difficult. I really become apprehended that whether I can provide so much time. But the thing is that when I attend any of the classes, then I feel that it is very much successful, and we have to make this type of arrangements in the future also, because we can bring great teachers in the platform, and we can arrange for very important lectures, and also the students who join the meeting, they can receive so many things here. Thank you, Professor H.M. Nazmul Hasan, for your great thinking, for great support. So I'll be expecting that when the days will be there, so you'll be with us all the time. Without you, we cannot think of a single meeting from ACP chapter Bangladesh. Whatever the year is, it is 2030 or 2041, you'll be there, inshallah. Now the question of the speaker. The speaker is my friend, and he is the father, he is the pioneer of nephrology in a setting when there was nothing like that to treat the patients of renal dysfunction in CMH. And I was fortunate enough to attend some of the beginning struggles with Professor Mamun Mostafi in CMH. So I found his activity that is so important to support the patients with kidney dysfunction, and definitely he created an environment that really is now cost worthy and also producing an area where people can receive the best of the treatment when there is some renal problem. So thank you very much, Professor Mamun Mostafi, for giving us time in this ACP chapters meeting, because I know that how much you provide from your time for academic purposes. I understand. I want to give thanks to the organizers to select Professor Mamun Mostafi for this presentation, especially this acute kidney injury. And I was amazed. I was, spellbound. I was listening to every line of the presentation, and I found so many important things, and those are summarized in such a nice fashion that anybody who is taking preparation for AKI or just treating the patients in his clinical practice having AKI. So definitely it was a very important meeting from as discussed by Professor Mamun Mostafi. Thank you again, Professor Mamun Mostafi, for bringing so good information to us and also pinpointing every important aspect to detect AKI, to understand the AKI, to treat AKI, and to follow AKI. Thank you very much again. And two of the expert members. And really, I was thinking that whether anything was left aside by Professor Mamun Mostafi. Then I was really very happy that two of the speakers, Professor Dr. Mahfuz, is a very keen student of medicine. I will say that I am seeing that he is a teacher, he is the head of the department of a very renowned medical college. But whenever I find some academic discussions are there, Professor Mahfuz is there. And also, I could learn so many things from Professor Mahfuz, what he said about AKI. So many things were added by Professor Mahfuz Rahman. I like to give thanks to Professor Mahfuz. So I do believe in the coming future, your presence in this type of meetings will encourage the students, and definitely our programs will be enriched by great teachers. And also another friend of mine, Professor Muhammad Zahiruddin, he is also a very great teacher, very good clinician. And also I found so many important things on AKI, what he mentioned. Really speaking, those are the key points and the practice points. When a doctor will find a patient of your AKI, then what you'll have to do. This was discussed by Professor Zahir and also from Dr. Professor Mahfuz. So in summary, I can say it's a long story of AKI. AKI begins with injudicious use of drugs, toxins, and some injury by your many types of trauma, either physical, chemical, or some biochemical trauma. And also we can see that the infections are there. So it is a very important aspect which is to be remembered by every physician in their clinical practice. So the story begins with this type of injury, and also the story continues when the patient presents if everything is not detected properly. What Professor Mamun Mostafi discussed line by line, word by word, that this is the point, you have to think like this. This is the point, you have to think like this. So I do believe that in our context at this moment, any other conditions, let it be recognized, but most importantly, what I would say that injudicious use of drugs, on most of the occasions we find that the patient might have some sort of your irreversible injury to the kidney. Definitely we'll be expecting that the AKI recovers completely, but it will produce really a very grave situation if glomeruli are also affected. So that is very important. So I will say that we could learn. I'm not going to repeat the things, and because whatever Professor Mamun said and also discussed by Professor Mahfuz and Professor Zahir, nothing is to be added. So very importantly, I will say that definitely today's meeting was a successful meeting, and the students who appeared to be there, definitely they got so many points to remember in their clinical life and also for their exam. Thank you very much again. And so every student, every attendee in the meeting, I would say that like me, as I was satisfied, I was benefited. So I feel that you also are benefited, and definitely a very good, the felicitations for Professor Mamun Mostafi. Thank you very much. So, Assalamu alaikum. Good night.
Assalamu alaikum, sir.
Sadly, we have come to the end of today's program. We have learned so many important things about AKI from Sir today. Many thanks to the speaker, the chair, the panelist, and last but not least, the moderator Bhaiya for managing time for this program from their very busy schedule. I would like to thank all the audience who were with us throughout the event, especially those who asked very interesting questions. Hope you got your answer. If you joined late or couldn't see the whole program, there is no need to be worried. You will find the whole program on the YouTube right after the live session finishes. Our next health talk on acute medicine will be held on 16th of September. So, see you all in the next episode. Until then, take care and good night.